Welcome everyone today to Stonegate's call. We are covering topical issues that are relevant to the biotech industry, and today we have a very special call with you with Palisade Bio and some data that they've released this morning. Palisade Bio is a clinical stage biotech company that is advancing therapies for acute and chronic gastrointestinal complications, and they announced data from pooled analysis of studies that are featured today at the Next Big Thing session of the Society of American Gastrointestinal and Endoscopic Surgeons, SAGES, 2022 annual meeting being held in Denver. Among the highlights from this presentation was that their lead drug, Palisade's lead drug, LB1148, reduced incidence of adhesions by 72% in patients undergoing bowel resection. So this, just on the surface, looks like a very, very good news. To discuss these data with us, we have two amazing speakers, and very soon I'm going to hand it off to them. The first is Dr. Ronald Hurst. He's a board-certified surgeon as part of the Division of Surgical Oncology at the Angeles Clinic and Research Institute. He will be presenting the data. Also, we have Dr. Michael Dawson, who brings both clinical expertise and background in research and development. He's the Chief Medical Officer at Palisade Bio. We also have on the call Tom Halem, who will be participating in the Q&A part of the call towards the end of the call. So how the call is structured is we'll have maybe a 15, 20, maybe 25-minute discussion from Dr. Hurst and Dr. Dawson, and then we'll take some questions. So without any further ado, let me turn over to Dr. Dawson and Hurst. Go ahead.
Next slide, please. Next slide. Good morning. I'm Michael Dawson. I'm the Chief Medical Officer at Palisade Bio, and I'm here to discuss some pooled study analysis that we performed of two studies that we've used to evaluate adhesions, abdominal adhesions in the post-surgical setting with our lead drug candidate, LB1148. So overall, I'm going to hit some key points, and then we'll talk further about the studies themselves and give some background. In our pooled analysis, we found that LB1148 reduced the incidence of adhesions by 72%. LB1148 reduced the extent and severity of adhesions, or how much adhesion there was and how developed they were, by 92%. By reducing this adhesion formation in the post-surgical setting, this drug has the potential to address a burdensome and very expensive complication of surgery, which I'll get into later. These data are presenting a potentially new mechanism of pharmacological development using protease inhibition at the gastrointestinal level to affect systemic pathologies. We also would like to note that we have a strong safety profile with more than 100 patients treated with our drug in the clinical setting with no serious adverse events. Next slide. So post-surgical adhesions historically develop in approximately 93% of all abdominal surgical procedures. Normally, the bowel has a smooth surface and it moves and glides within the omentum and peritoneum without obstruction or issues in terms of peristalsis. Adhesions are scar tissue that form during a healing process, and they bind the bowel together or to the abdominal wall or to the viscera. So what our hypothesis is at Palisade Bio is that proteases that are within the bowel lumen translocate during manipulation and surgical processes and lead to adhesion formation through an inflammatory cascade. These bands of adhesion, they bind the tissues together and they cause organ strangulation, pain, and even obstruction, sometimes leading to ischemia. Next slide. So here's an example of a post-surgical adhesion. It's a band of connective tissue that is not normally formed that connects together two pieces of the bowel. Adhesions can form anywhere in the abdomen. The most common types are bowel to abdominal wall, bowel to bowel, and bowel to viscera, and they affect the actual movement of the bowel, and they can cause dilatation and obstruction. They look like either thin sheets of cellophane, or they can go all the way up to being very organized, thick band-like tissues with neurovascular bundles. However, even the smallest thin band-like adhesion can be pathological and cause obstruction. Next slide. So I'd like to discuss this as an unmet medical need in the present day modern surgical setting. We know that up to 93% of abdominal procedures can result in adhesions, and we know that this is the #1 cause of bowel obstruction. It's also the 10th most frequent cause of emergency surgery, and it leads to 80% of emergency surgical deaths. 400,000 adhesiolysis surgeries are performed in the US annually, and that is a surgery that requires takedown of adhesions to either relieve symptoms or to perform a surgical procedure. And we also realize that there's approximately a $2.3 billion cost to the medical industry to deal with these adhesions on an annual basis. Next slide. So I'm going to talk about two existing devices that are available to treat adhesions. First is Seprafilm. Seprafilm is a device. It's a thin coating of material that is placed between the incision and the abdominal wall to prevent the incision to abdominal wall adhesion that I described previously. Seprafilm is studied in, approved, and designed for laparotomies, not laparoscopies. It does also disrupt the surgical process in the fact that it's an extra step that has to be performed, and it can extend the duration of the anesthesia procedure. Next slide. The second device that's approved is the Adept Hydroflotation Medical Device. And what this does is it's a device that uses a peritoneal style dialysate through a irrigation procedure that is added to the peritoneal fluid, and it floats the fluid and provides a barrier for adhesion formation. It provides a physical effect that temporarily separates the peritoneal surfaces due to this hydroflotation technique. Adept is approved for gynecological laparoscopic procedures, and even though its efficacy was less than 10%, it was approved by the FDA. Next slide.
So let's take a moment to talk about how digestive proteases and the breakdown of the intestinal mucosal barrier can drive the adhesion formation process. Normally, the intestinal mucosal barrier maintains these potent digestive enzymes within the lumen of the intestine. However, the barrier can be compromised as a result of injury to tissue trauma related to surgery. This leads to an inflammatory cascade and subsequent damage to healthy tissues. When the intestine's mucosal barrier is compromised, this results in an escape or a leakage of the digestive enzymes, also called proteases. These proteases seep into the intestinal tissues, driving a destructive cascade of disease mechanisms called autodigestion. And this includes the proteolytic activity to the tissue damage. This creates a negative feedback loop, damaging the intestinal tight junctions, increasing proteolytic leakage, intestinal damage, and further exacerbates this with postoperative complications such as adhesions and inflammation. We believe that the escape of these rogue proteases is the primary driver of the formation of aberrant post-surgical abdominal and pelvic adhesions. Thus, the primary focus of Palisade Bio's therapeutics are to inhibit the activity of digestive proteases leaking from the gut during surgery that cause the damage and drive this formation of adhesions. Next slide. To address the formation of post-surgical adhesions, we've created LB1148. This is a proprietary, patent-protected formulation of an oral liquid serine protease inhibitor called tranexamic acid. It is formulated in already approved FDA components. Patients drink LB1148 in conjunction with surgery to coat the intestinal mucosal barrier and protect the intestines during surgery. LB1148 is staged for regulatory success, as its components already have established safety profiles, and the drug has received fast track designation from the US FDA for reducing post-surgical abdominal and pelvic adhesions. Next slide. One of the keys is that the patient takes this drug at home prior to hospital administration. And in particular, when you're evaluating the commercial opportunity, it's important to understand how we expect this patient journey to evolve. Importantly, about 1 to 2 weeks prior to surgery, a patient would receive a prescription for LB1148 during their preoperative office visit, and then have this prescription filled at the local pharmacy, where it would normally be covered by the patient's pharmacy benefit. The patient would then arrive at the hospital for surgery, having already taken the first dose of LB1148 the evening before surgery, and then a second split dose the morning of surgery. Following surgery, we expect LB1148 would reduce the formation of adhesions. And because hospitals in most cases would not be paying directly for LB1148 from their DRG payments, we believe this eliminates a potential barrier or willingness to add LB1148 to perioperative surgical protocols. Next slide. Before going into the human data, I think it's really important to discuss and review some of the data that we have from our animal studies demonstrating that LB1148 reduces adhesion formation. Here are data from an animal study demonstrating a 63% reduction in post-surgical adhesions. In this study, animals underwent a surgical procedure to resect a 2-centimeter piece of bowel, and then were allowed to recover for 7 weeks. This is an animal model that closely resembles the human surgical procedure for bowel resection with anastomosis. As these images on the right demonstrate, animals treated with vehicle have extensive adhesion formation that leads to abnormal bowel anatomy, inflammation, and pathology. And you can see in the animals treated with LB1148, they have normal GI anatomy in the absence of pathological adhesions. This data is quantified on the graph, and you can see it's statistically significant 63% reduction in adhesions in the LB1148 group. Next slide. Here are data from a separate study with an animal model of abdominal surgery without an anerotomy or an incision into the gastrointestinal tract. In this study, animals underwent a laparotomy. The bowel was exposed and rubbed gently with a surgical glove 10 times, and the laparotomy was closed. And the animals were allowed to recover for 28 days before quantifying the adhesions. This model replicates the manipulation of a bowel that we observed in abdominal or pelvic surgery, like a cholecystectomy or fibroidectomy. As you can see, the animals treated with LB1148 before surgery had a 78% fewer adhesions compared to control animals, and LB1148 reduced the severity of post-surgical adhesions by 62%. And these reductions are statistically significant. Importantly, when we look at data from multiple studies, they begin to tell a story. And what we have here are data from multiple animal models demonstrating LB1148 reduces post-surgical abdominal adhesions. And we believe these data would be indicative of the reductions that would be observed in human clinical studies. And with that, I'll turn it over to Dr. Dawson to describe the clinical data.
Thank you, Tom. So I'd like to quickly talk about the two study designs that we used to pool this analysis. The first was an open label phase 1 GI surgical study, which was sponsored by an investigator, Dr. Hurst, who's here today, in Los Angeles. 11 subjects were treated, but a total of 3 subjects fell into what we call our adhesion bracket, where they received a second surgery where their adhesions could be graded at the time of the second surgery. At that second surgery, you can see at the far right, adhesion indications were graded for extent and severity, which I'll explain in just a few minutes. So patients were given the drug 2 to 6 hours prior to surgery and then 6 to 12 hours prior to surgery. They had their surgery, they had their follow-up, and these 3 patients we'll talk about had a second surgery at a later time. Next slide. The second study was a randomized double-blind, placebo-controlled, multi-site phase 2 study. And this study was similar in administration in the fact that the patient received the drug 2 to 6 hours prior to the surgery and 6 to 10 hours prior to surgery. And they received either drug or placebo. Again, a 14-day follow-up in the hospital with a 30-day follow-up, followed by a group of patients, in this case 14 patients, received a second surgery within 7 months of the initial surgery. Of those 14 patients, 9 were placebo and 5 were drug treated. Again, the endpoint that we're discussing today was the presence of adhesions or incidence, and also the extent and severity of those adhesions. Next slide. So LB1148 is a safe and well-tolerated drug. We are also following the 505 B2 pathway for this drug with a known safety protocol for our active ingredient. It was well tolerated in both of these studies, with drug-related events being 10.9% versus 4.8% for placebo. The most common event was a GI disorder, and that most common was diarrhea. There were no drug-related serious adverse events that occurred within any of our trials. Next slide. So here's a key demographic breakdown. I'd like to just point out that the ratios of the median age were very similar. There was a slight predominance of the male in the placebo group, but overall, these were colorectal cancer patients. And I'd also like to point out the approach. In the Chinese phase 2 randomized double-blind controlled study, all 9 patients were minimally invasive techniques. And in the open label principal investigator sponsored study, in the placebo group, and in the drug treated group, there was in the minimally invasive were 6 and open laparotomies were 2. Next slide. So let's talk about our grading system and how we're performing our clinical trials. This is a grading system that uses both extent and severity. Extent is the geographical distribution of the adhesion within the abdominal cavity. So a surgeon will then look and divide the abdominal cavity into 9 quadrants as shown by the diagram. Some surgeons will sweep it from A all the way through H and then finish up in I, like a clock. And when they go to each of these quadrants, they will grade the extent or how much coverage in that quadrant there's of the adhesion, with less than 1/3 being a 1 and greater than 2/3 or completely covering the quadrant being a 3. We also have the surgeon grade the severity of the adhesion or the type of adhesion. If it's a filmy, thin adhesion, one that can be taken down with blunt dissection easily, it's a 1. If it's one of the adhesions I described earlier that's dense, nodular, and is vascularized, that cannot be taken down except for with adhesiolysis, then it's a 3. When these scores are done and all 9 quadrants are rated, then it's summated into what we call the abdominal adhesion burden, which is the combination of extent and severity. So let's talk about our data that we have. So LB1148 demonstrated a 72% reduction in overall adhesions. If we look at incidence, which is just whether you have 1 adhesion or not, if you have 5 adhesions, you have 1 for incidence, and if you have 0 adhesions, you have 0. So this is just the incidence. In the placebo group, 8 of 9 of the patients, or 89%, formed adhesions. I think it's important to point out that most of these studies, patients that we had, were minimally invasive techniques. So even though historically the rate is 93% that included a combination of laparoscopes and laparotomies, we still proved in our placebo group that adhesions do form even with minimally invasive techniques. In our drug-treated group, we had 2 patients that had adhesions out of 8 that were treated with drugs, which gives an incidence of approximately 25%. The relative risk reduction between these 2 groups was 72%, which was statistically significant. This reduced the absolute risk by 64%. LB1148 also reduced, as I was describing before, the extent and severity of adhesion. So in the placebo group, the extent and severity mean was 14.3%, or a combination of how dense or how organized the adhesions were and how much they covered geographically. However, in the LB1148 treated group, the mean for the combination of extent and severity was 1.0. That's a 93% reduction in the overall compared to placebo. The reason why extent and severity are important, and I will talk about this a little bit later, is that we believe that the more adhesions you have formed, the more organized they are, the more long-term complications as a patient you will have, including obstruction and possible ischemia and secondary surgeries. Next slide. So here are some key findings that I already talked about. LB1148 reduced the relative risk of adhesions by 72%. LB1148 reduced the extent and the severity, or the adhesion burden, by 93%. The incidence of adhesions in the placebo group was within the expected published incidence, with the placebo-treated subjects' laparoscopic procedures being 100% and LB1148 having 75% laparoscopic procedures. Next slide. So I have my colleague, Dr. Ronald Hurst from the Angeles Clinic, or Cedars-Sinai in Los Angeles, who is our principal investigator for our open label study. And I'd like to ask him a few questions about our drug and also the studies that he performed. Good morning, Dr. Hurst. Would you like to comment on adhesion pathology in your patient population and practice?
Yes, adhesion pathology is a very significant unmet surgical need in our industry. It's very challenging for us to encounter adhesion. It's one of those cases as surgeons, is something we really truly do not like to engage with, because the morbidity can be significant with repeated operations for the same process, or even sometimes in the extent of the adhesions, whether it's a single adhesion or multiple adhesions, the outcome can be adverse for the patient, whether it's one operation or multiple. So it is a significant clinical process for us practicing surgeons.
And as in terms of an unmet medical need, do you happen to use Seprafilm or Adept in your practice?
I do not. Never used Adept, and in my early training days, I did use Seprafilm. But Seprafilm was very lukewarm. wasn't warm and fuzzy at all. It's very difficult to administer for open laparotomy cases because it's very difficult to handle, and the outcomes were not that significant clinically. So we stopped using it.
And how was LB1148 with your use? And I know that you used it in multiple patients in open label study, but you also had 3 that you used for your second surgery in adhesions. How did this fit into your scope of practice, and did you have to change anything when you used LB1148?
Actually, what I liked about LB1148 for 2 perspectives. One, for me as a practicing surgeon, it was seamless. It was very easy to educate the patient preoperatively because it's part of a bowel prep, which is already part of our discussion process with regards to surgeries, whether done minimally invasively or open. So it's seamless from a clinical surgical perspective. From the patient's perspective, it was an easy bowel prep. Every patient that enrolled in the trial, my open label trial, had no complaints with regards to the administration, how it was administered, the taste, the outcomes. It was very simple for them to administer at home. So it did not impact the clinical practice.
Great. And in terms of the LB1148 treated abdomen, can you describe what these patients' abdomens look like when you went in for the second surgery with your scopes and did an evaluation or a non-quadrant evaluation? And also, if you don't mind, could you comment on the adhesion levels in these patients?
Absolutely. What was most profound, a lot of my patients that were part of this trial were cancer patients, and a lot of them involved rectal cancer or colon cancer. And the ones that had the second look operation were rectal cancer patients, 2 of which received preoperative radiation. So I would have expected an extent of a radiation adhesion-induced adhesions at the time of operation. What I found in a couple of these patients were they both had ended up having diverted ileostomies. The first case had diverting ileostomy as a protective ileostomy. And when this patient was taken back to surgery, approximately 10 days to 15 days after his initial surgery, about a month, had a peristoma hernia. So I opened the patient to fix the peristoma hernia, and to my surprise, I was able to evaluate the extent and severity of adhesions post administration of LB1148, and the extent and grade was 0 on both accounts, which was profound and very exciting at the time. So when I fixed his peristoma hernia, he returned 5 months later to have his ileostomy reversed, and his extent and severity 5 months post administration of LB1148 were 1 and 1. So 2 and 2. It was pretty significant. It was an easy approach. It was minimal adhesions. It was quite surprising. So that was profound. The other patient also had extensive preoperative radiation for her rectal cancer, who subsequently developed a colovascular fistula. So I took the patient back to attempt to repair that. And what I found, the abdomen was essentially a extent and severity of 0 and 0. Again, very surprised with the data, excited to see that, and gave her a protective ileostomy. And she did very well too. So those 2 cases were profound examples of the impact that I saw as I believe, directly related to the administration of LB1148.
And how do you think that LB1148 might be utilized in future surgeries moving forward?
Well, I think it's a game changer. I think it's a paradigm shift with the administration of the drug, of how it's done. easy to explain to patients, where it's seamless for them, because we don't want to make things too complicated for patients with regards to their surgical procedures. And adding this one small entity as part of their procedure is simple. Second, it's translatable to surgical outcomes, because if the patient does not have minimal to no adhesions post-surgery, that's impacts the patient for subsequent operations. So we can then have this discussion with these patients preoperatively, like, with this administration of this drug, this is the benefit that you can gain, and the data supports that. So I think it's significant.
Well, thank you, Dr. Hurst, for commenting on being the principal investigator in one arm of our study. Next slide. Tom?
Sure. So I think, in conclusion, this is a really exciting development here at Palisade Bio. Importantly, what we really have is this fantastic data where, with a pooled analysis, we've been able to demonstrate that LB1148 has the potential to reduce intra-abdominal adhesions following surgery. And so what are the next steps for LB1148? Importantly, we have an ongoing phase 2 clinical study in the US that's going to be capturing additional data with adhesion prevention. We expect the completion of enrollment of that study in the second half of 2022. And we're transitioning LB1148 to phase 3 to accelerate the return of bowel function in a phase 3 study that we'll be discussing later on more this year as well. And so it's a very exciting time for Palisade Bio, and particularly for the development of LB1148. And with that, I'll turn it back to Shiv to see if there's any questions.
Fantastic. That was a great presentation. Thank you so much, Dr. Dawson and Dr. Hurst. And thank you, Tom. If you have any questions, you can raise your hand, and Errol will come out and pick you. You can also send the questions through the chat to the panelists, and I'll read out the questions. And while we're waiting for any first questions, perhaps I can start with one. Dr. Hurst, you mentioned that this is sort of a game changer and sort of a paradigm shift in this kind of therapy. Can you tell us what other drugs or advances in this area have been as big? It seems like it's something that will change how you treat patients drastically. And given the low p-value in just a small number of patients, it seems very powerful data. So when did you last see similar data like this, and how do you envision using this drug once it's approved?
Well, very good question, Shiv. The interesting thing is there has not been any really good significant data out there with regards to the direct specific endpoint of prevention of adhesions. Seprevim has sort of been that paramount method for decades. Now, Seprevim has probably been out a good 20 plus years out there in the marketplace, and it still has not impacted significantly with regards to clinical outcomes and reducing the morbidity and mortality from adhesions, simply because of, although it's a low number as far as the efficacy, even though it's FDA approved for that, the outcomes clinically are not translatable because it's difficult to use and it's not a fan favorite of surgeons. It's the only real option out there. So there's not a lot of data. So if you take that perspective and correlate it with what we are getting from LB1148, that's why I say it's a game changer, because it makes it easy for the surgeons to administer, it's easy for the patient to administer, and the outcomes are very promising.
Fantastic. I have a question from Aiden Husnov, and I'm just going to read the question, and then I have a related question of my own. The question is, could you talk a little bit about the phase 3 study design and potential endpoints? Can adhesion score be an endpoint? And how would these endpoints compare to the endpoints of the ENTEREG study?
I'll just start by making sure there's one clarification. When we talk about a phase 3 study design, that phase 3 would be for the acceleration of return of bowel function. For the focus from an adhesions perspective is the ongoing phase 2 clinical study in the United States. But I'll let Dr. Dawson talk about the adhesion score and why we think this is really an important aspect of clinical trial design, particularly at this stage of phase 2. Dr. Dawson?
Sure. So the adhesion burden, which combines the extent and severity, is the amount of adhesion and how organized they are within the abdomen. We believe that there is scientific backing of this in addition to KOL opinion, that the more abdominal adhesion burden you have, the greater risk you are of your lifetime of having an event, such as pain, cramping, or even going to the OR and having palliative means of relieving your adhesions or an NG tube. In the more severe cases, this can lead to obstruction, bowel ischemia, emergency surgery, and even death. What we're doing in our studies is we're measuring both the adhesion burden and the incidence. Incidence we feel is important is because incidence is how the regulatory body, the FDA, approved Adept and Seprofoam. So we're following both the lines that we feel like we can show that we can reduce the overall incidence, but we can also reduce the overall adhesion burden, which should correlate to less complications for the patient's lifetime.
Fantastic. I have a question from Dan Horowitz, and the question is, how would a fast track designation come into play, assuming that it would?
Well, I think more than anything, right, what does fast track designation do, right, is it gives us greater access to the FDA and to the agency and more expedited reviews. And I think that, really that has been the development of and we see that in our interactions with the regulatory authorities, and particularly the FDA, that there has been a very, how do I use the word, collaborative communication, and that we really hope that these accelerated reviews over the life of the program will help the development process and hopefully ultimately regulatory reviews of LB 1148.
Fantastic. There's a question from Naz Rahman at Maxim. The question is, could you talk about the severity and timing of the AEs? Were the AEs mostly mild, moderate, or severe? And also, were the AEs transitory, or did they last for a while? And there's one more question, but I'll ask later.
Sure. So the AEs were transitory. They were mild, and they tended to be in the immediate postoperative setting, and there were no prolonged adverse events that we've noted so far in our trials.
Was there a difference between the drug group and the placebo group in the AEs?
Yes.
Did they come sooner? Yeah, go ahead.
There was a slight difference. It was not great, but there were slightly more AEs in the drug-treated groups than the placebo.
Another question from Naz. Can you talk about why there was a higher rate of placebo patients that required a second look surgery versus LB 1148?
Yeah, I think you're referring to the Chinese study, and that was just random. I feel like once we perform the next 70 to 100 patients, they'll parse into two separate groups and they'll be balanced. This is just because there were small numbers.
I see. Did you notice a difference in the LOS for patients for LB 1148 versus placebo patients post-surgery?
We haven't announced any the data on LOS. We hope to be doing that at a future medical conference.
Do you expect to see any challenges in the way of side effects from TXA for phase 2, phase 3?
I think I can answer that and also answer another question where it was asked, are there any thromboembolic complications?
Yes.
So theoretically, tranexamic acid has a thromboembolic complication related to its plasminogen effects. But we also can point to several studies, the CRASH 1 and 2 studies, in addition to a meta-analysis performed in 2012, that demonstrated that no statistical significance of thromboembolic events, DVTs, or pulmonary emboli in patients treated with tranexamic acid. Also, I'd like to show that in the patients that we've treated in our study so far, we have seen no thromboembolic events at all. We are tracking those events per the regulatory body, the FDA, but so far we have seen none of these events.
That's fantastic. Perhaps I can ask one in the end myself. It's very rare that you see. It was a study that was under 20 patients, and you're seeing p-values of significantly under 0.05, 0.01 something. So this must be very, very exciting, given that if such results can be seen again in larger studies. This would be, like Dr. Hurst said, it could be a game changer. What other studies, in addition to what you have been running, could be run to kind of explore those areas?
That's a great question. There's one of the things about this drug, I think, is that there's with this oral administration prior to surgery, there's a lot of different surgery types that we could potentially utilize this drug for, and a number of different surgery-related endpoints. But for today, we're really focusing on two things, right? We're focusing first on the acceleration of the return of bowel function, which we have very strong data from phase 2, highly statistically significant, demonstrating a over 25-hour improvement in acceleration of the return of bowel function. And now these data showing that the LB1148 reduces both the incidence and the extent and severity of adhesions in the postoperative setting. So from today's perspective, we're really focusing with those indications and advancing those programs in the clinic.
Fantastic. Well, we're coming to a close to our event. Thank you, Tom, for being here, Dr. Hurst and Dr. Dawson, for the scientific discussion and presentation. A recording of this call will be available for viewing later on both our website and on Palisade Bio's website. If you have questions that haven't been answered here, please feel free to reach Dawn Hoffmeister at Palisade Bio. Her contact information is in the press release that was released this morning. So with that, thank you everyone for joining us. And again, congratulations to the company for just some fantastic data.